Wonderful. Hello, everybody. Good to see you all coming in. We're going to give a few moments for the Zoom boxes to fill in and for people to connect to their audio and video. I hope this time we won't have any power outages. I know last time we had power outage in the middle of comments. Hopefully there's good weather today and no disruptions. Roxanne, I see you there. Good to see you.
Hi, how are you?
Good, good. It's hard to believe that it's March, to be honest. Time is just galloping by at a pace that baffles me.
I know it does. It goes by so fast.
And here's Amy, one of our steering committee members. Hi, Amy. Good to see you. And Sierra, one of our funded researchers, I see. So good to see you all here. Thank you for making this time on this Friday afternoon. All right, I see there's like one more audio connection that's coming in. Well, a couple more audio connections. All right, so Hazel, first part's on things you have already seen before, so we're going to go with that. If you could start sharing some screens, Hazel. All right, my name is Bettina Höppner, and I want to welcome you all on behalf of our steering committee, who you can see here, and you've seen Amy wave on her camera earlier today. John, who is the principal investigator together with me, is not here right now. He's giving a presentation, is hoping to be here later on still. We're excited to have you here. As you know, this is a NIDA-funded initiative to help us all, a number of different stakeholder groups, to come together to help advance the science on recovery community centers. A couple of minutes ago, in the pre-meeting, we were talking about how long the RCCs are presenting today have been open, and how it's difficult to pinpoint the exact time the first RCC opened, because it's a recent term and every RCC is different. So part of our initiative is to understand that diversity and to understand how RCCs operate in different areas. So next slide, Hazel. What we're doing currently, which is sparked by questions that you all raised in our seminars, is this nationwide survey we have mentioned to you all. This is twofold. We want to know how many RCCs currently exist in the United States, and we want to know how they operate and what they do, just so that we can document that. And then the second part is to actually get feedback from you all about potential outcome measures that could be used. Like if you're asking participants that walk through your door on the first day, and then 6 months later, how would you show improvement, and what would be an appropriate measure of that? So the survey is towards that goal, to figure out what are the best measures we can use to document effectiveness. So if you have not already, please complete the survey. We will also reach out to you, but certainly reach out to us to complete the survey. We'll be ever so grateful. And down here, the PDF link, if you click on that, Hazel, can you also throw it into the chat? You can click on that, and that gives you all the details about that survey. Currently, we are aware of 240 RCCs, and that's probably more because we keep learning about more. So also let us know if there's somebody we haven't reached out to who we should have reached out to. Next slide, please. All right, as you all know, we always have our live feature, and there are some people in the room who are less familiar with recovery community centers than others. And of course, every RCC is also different than any other RCC. So we always want to give a glimpse, a view into what it is like when somebody walks through the door of a particular RCC. With us today, Ms. Heather Rodriguez and Mr. Brandon George from the Indiana Addictions Issues Coalition, and they're going to give us a live feature. So I'll turn it over to you guys, Heather and Brandon.
Thank you, and thank you for inviting us to present a little bit about our RCC. And I'm just going to kind of stick with the talking points that I was provided by Bettina and team. And so, as mentioned, I'm Heather Rodriguez. I'm the Manager of Recovery Community Development with Indiana Addictions Issues Coalition, which is a statewide RCO. I'm also the Director of the Indiana Recovery Network, which is a statewide organization, and we oversee a regional recovery hub program that consists of 20 recovery organizations, many of which are located in rural communities. So we certainly have a lot of information and experience working through RCCs in rural areas in our state. And so for us and our RCC, we are located in Indianapolis, Indiana. So obviously that's an urban environment. We were slated to open our RCC in 2020. However, that was delayed due to COVID, as y'all can imagine. But that actually provided us an opportunity to do some kind of remodeling and really kind of get a vision for what we wanted our space to be. And then so we were able to open our doors finally in July of 2021. And so one of the questions was, who do we serve? Well, we like to think of ourselves as a no barrier drop-in center, meaning that we do not have any membership requirements. There are no expectations from any folks that come into our doors. We just want to provide a safe space for folks who are in or seeking recovery at any stage of change that they're in. A lot of the individuals that we see being located in pretty much downtown Indianapolis are individuals who are experiencing homelessness. We get a lot of folks that have co-occurring concerns. A lot of folks in the reentry population, and then just anyone in between. So we really are just open to anyone who wants to come in and get connected with recovery supports and services. We are open currently Tuesday through Thursday from 9 a.m. to 5 p.m. We will be expanding our hours in the summer, hopefully a little bit more evening hours and some more fun activities for folks who want to come in and enjoy those. And so what happens when someone first walks through our doors? Well, the first thing that we have is we really try to be mindful about the types of things that we hang on our walls. Is it representative of multiple cultures and things like that, and really inviting to let people know that everybody is welcome here. And then also being mindful of the language that we use, and so no stigmatizing language, things of that nature, of course. Then we have a resource table. So that's also the first thing people see. And that consists of a wide variety of resources. So anything from, where folks can go to get connected to food, transportation, housing, mental health or substance use treatment, and transportation, just a wide variety of things, as well as we like to connect people to other RCCs in our area, because, we're all on the same side trying to help people help themselves. And so we want to share information about our community partners that are also in existence in this space. Then we have a front desk located in our lobby, where we always have a team member who's posted up there to just welcome and greet people, make them feel, like at home. We offer light snacks, coffee, water, and just let folks know, help yourselves to whatever it is you need. Sometimes people just like to come in and just have a nice quiet space to be, right? Especially in the colder months here in Indiana. As mentioned, we have some unhoused folks that like to come in and they just like to have a warm space. Maybe they might close their eyes for a few minutes, and that's okay. Like, we're here for them, whatever they need. So we do that, or we'll provide one-on-one recovery coaching sessions. We have a couple of groups that run, so it's really whatever folks want. We also have a kiddie area. So we have a space for if somebody wants to come in, have an individual session, attend a group, maybe they don't have childcare, one of us will pitch in, hang out with the kiddo, do whatever, so the guardian can still have that connection, again, decreasing that barrier to access, right? And so I am located in our center right now in our space that we have affectionately called Da Vinci's Den, which is named after a true pioneer in the recovery movement here in our city. He was just an awesome, awesome person, really championed for folks in reentry population and underserved and marginalized communities here in Indianapolis. Sadly, we lost him due to COVID in 2020, and we thought this would be a great way to honor his memory. So getting a little on the feelings, but that's where I'm at right now. And so as you can see behind me, we have a community computer space with a printer, so folks can come in, they can apply for different social service programs, check their email, whatever they need, go at it, just, nothing funky. We have a PlayStation, TV, games, coloring books, all that kind of stuff. And so sometimes folks come in, maybe they want to hang out and just play cards or something like that, we'll do that with them too, whatever they need. Let me get on track here. Okay. And then, so what do I love about our center? And Brandon can chime in too. Again, I love that we are actually a no barrier access point to services and connection. There's no membership requirements. We don't have an abstinence-based policy. We welcome all pathways to recovery. And I am particularly proud of just the way that we were able to open a drop-in center here in Indianapolis. Again, we do have some community partners that have an RCC, and there's some requirements that maybe isn't a best fit for other people, or it's kind of shied them away from that connection. Again, we just meet people where they are. Whatever you want, we're here to help however we can. And I think that's all I have. I don't know if Brandon wants to add anything to that.
Well, Heather, thank you. And I think it's a really good representation of the center. And just it's so hard to get access to care. And even folks that want to, like, unless you're in the prep or action stages of change, you usually can't get help. It's like, okay, unless you're ready to quit using and do XYZ and you have the right insurance, et cetera, then we'll help you. And we want to make sure that we are getting folks no matter where they're at in the stages of change, and having open access to fentanyl test strips, naloxone, et cetera, which we do at the center is a big piece of it. We do also, just I guess one note is we do a lot of outreach, harm reduction outreach out of the center. We serve kind of as the hub. We make hundreds and hundreds of backpacks with Narcan, socks, water bottles, et cetera, that we give to all the RCOs around the state and RCCs around the state. They come and get them, and we do outreach teams to do that, especially in high overdose spots. So it's neat. It's neat to see this field grow. We're glad to play just a really, really small piece of it. And so we appreciate the invite.
Wonderful. Thank you for being here with us today and telling us about your RCC. Hazel, could we get the slide back? Because we're moving into our polling questions now. So as you know, we always do a polling question to see who's in the room, and then to ask a question that kind of previews the presenters to come. So if you could fill this out, you do need to scroll down. There's a gray thing at the side. You have a new polling window that came up. And then when you go all the way to the bottom, you can click on the submit button. I'll give you all a few minutes to do that. All right, how are we looking, Hazel?
We have a very small amount who've done it so far, so I think there's a lot of questions. So we
There
should
are. Plus, I've seen them before, so I have an advantage of reading through them.
Now we're at about 50% completion, so we can just give it a little bit longer, and then I can share the results.
Wonderful.
Okay, so I'm going to go ahead and end the poll and share it in about 10 seconds. So if you're finishing it up, try to get it in soon, and then I'll end the poll.
I was thinking this is our, protected time for a little mindfulness exercise, right? So we're waiting here in silence together.
Okay, so I just shared the results. So this should pop up on your screen, and you have to manually scroll through them yourself.
Exactly. So just jumping to our question down at the bottom here. So as you know, today's conversation is about rural RCCs. They've come up in a number of different seminars about the particular challenges that they have and how that plays out. So we asked here, what do you all believe is the biggest barrier to recovery support services in rural areas? And the number one thing that everybody talked about was transportation, with 42% of us thinking that was the biggest barrier. And then the lack of anonymity was something that we had originally thought was going to come up a lot, but you can see here it's only for 4% that it was really the biggest barrier. And then lack of peer support workers is another one that was on the lower end. So keep those in mind as you actually hear more from our speakers today. And then I was also curious about how much we know about the incidence rate of opioid use disorder in particular in urban areas. And we asked you all to say, well, what do we think? Is it more or less or the same in rural areas compared to urban areas? Or do we not know? And I will let Carrie answer that question for us. So without further ado, let me introduce Carrie Oser. Here's actually, let me say who all of our speakers are. Dr. Carrie Oser from University of Kentucky is going to be speaking first to give us some background on rural recovery, or rather recovery support service in rural areas. And then our two directors from RCCs, Mr. Joey Supina from Sandusky Artisans Recovery Community Center, and Mr. Jennifer Langston from REBOOT Jackson. And they will go in this order, and I will hand it over to you, Carrie.
Thank you so much. And thank you for having me here today. Can everybody see my screen okay?
Yes.
Good. So my name's Carrie Oser. I'm a professor at the University of Kentucky, and most of my research focuses on improving outcomes and both treatment outcomes and life outcomes for people with substance use disorders who are from vulnerable or underserved groups, including rural residents. So I'm happy to be here with you today. I wanted to share a quote from some of our research, and it's from a rural substance use disorder clinician. And this counselor was really just burned out and felt defeated. And that came through in some of our research from rural clinicians. And this rural clinician highlights how they felt like the underinvestment in rural substance use treatment is intentional, and that it was, he or she says here, I don't think any of that is by accident. I don't think that I'm undervalued by accident. I think my clients are supposed to die. And so this is a very kind of defeatist attitude that this counselor was sharing, but I think it also highlights that there's opportunity for hope. And that hope is through increasing recovery community centers in rural areas. There is a big landscape and opportunity for growth here. So before I get into rural recovery community centers, I wanted to share a bit of the landscape, and we'll get to that answer that was one of the polling questions. So in the US, about 1 in 5 people live in a rural land area. So it's about 60 million people. And the data really varies. Some of our studies have shown that there are higher rates of opioid use disorder in rural areas, and we see that portrayed in the media. While other studies have found higher opioid use disorder rates in urban areas, or just no significant difference. So it's really inconclusive. And some of that aligns with how we define rural. There are certain vulnerable rural populations that include youth, American Indians, people with comorbid health issues and disabilities, and also certain occupations. So when we think of rural, I think when everybody closes their eyes and think of what a rural area is, we probably all have a different perspective. We could be thinking of farmland, we could be thinking of the Southwest, we could be thinking of somewhere in the Northeast or the Great Plains, but there are varying definitions and ways to operationalize rural areas. It could be population size, it could be population density, proximity to a metropolitan area. And so we have to think about that when we are trying to digest data on substance use trends. There is heterogeneity or differences in the severity of the drug crisis in rural areas. And so it does depend on what drug type you're talking about. And is not consistent. So when you're talking about rural areas, you have to be specific if you're talking about the Mississippi Delta or Appalachia or different regions of the US. So here is a map of the US, and this is from a study by Carrie on opioid-related deaths. And you can see there's certain pockets that are higher for the opioid-related deaths. So here in rural Appalachia, we see up in the Northeast, and then the mountain region over here in the West. So I was asked to answer the question, why is it important to provide recovery support services in rural areas? And there are a lot of reasons. The first of which is that, as the data is a bit inconclusive, but some of it supports that people in rural areas have higher rates of substance use disorders. And we know that there are significant comorbid health conditions. And so individuals need access to recovery coaches to help them navigate those complex situations. It is also a billable service by Medicaid. The first state was Georgia back in 1997 to be able to bill Medicaid for recovery support services. And now 41 states have it on their Medicaid formulary. But what's unclear is if this is reaching rural areas, and we want to ensure that our rural residents have access to the wonderful services that the RCOs or RCCs are providing to individuals. In addition, the rural landscape has limited access to substance use disorder treatment. And in terms of inpatient, residential, outpatient services, but also just in terms of mutual self-help groups. Rural areas, since they're smaller, they may have, one AA/NA meeting per week in one church. And that's the only meeting. And if you work during that time, then you miss that meeting. I think the landscape is starting to change now, especially with COVID, to more virtual options, but it is still a barrier. And our recovery coaches in rural areas can help provide additional coaching sessions to individuals, both telephonically and in person. Also, having recovery support services in rural areas reduces stigma, it inspires hope, it builds community in rural areas, which are smaller insular networks, and it provides needed resources, services, and referrals. Transportation, which y'all mentioned, was the #1 barrier. A lot of recovery community organizations either have vans and will provide transportation themselves. They might have small grants to provide transportation vouchers or cover transportation. And that's a good time for a recovery coach to talk with the client and understand what their barriers are and help build that recovery capital. And even just fun things like Super Bowl parties in a healthy space are offered by the rural recovery community centers. Record expungement clinics, which help with some of that workforce development. And then of course, providing those linkage and connections to treatment, to harm reduction services, and also to other healthcare. I was also asked to share about unique barriers in rural areas. And so what I've done here is, this is data all from rural substance use counselors or clinicians, and there's some quotes that are included here. But they talk about the few substance use disorder treatment options. And this not only includes the actual treatment, but also detoxification services. And you can see in this top quote is by a rural counselor who also works at a psychiatric clinic. And this person was saying that they have to come into the psychiatric hospital and say that they're suicidal to get treatment for their withdrawal symptoms and in order to get detoxed. And that is obviously a challenge and a barrier in a rural area. Comorbid health conditions in terms of cardiovascular disease, diabetes, hepatitis C, those are all issues that are challenges, mental health issues as well. Transportation, which was mentioned in this group. Here is another quote that says, the #1 problem for many folks we have, they don't have a driver's license, they abused that privilege and lost it, they can't go to 12-step meetings, they can't go to work, they can't go to an IOP or any kind of counseling session, and they live 20 miles from wherever. and there's no public transportation in most rural areas. And so this is a huge barrier to treatment and to access to recovery services. Housing is a significant need. There's few recovery housing options, and especially for individuals coming out of jails and prisons. And then there's also that lack of anonymity. If there's one treatment center, or even at the rural recovery community center, people know in a small town what those agencies are, and there may be some watching or surveillance of those to see who is coming in and out of those buildings. And that's related to stigma and where agencies are placed in rural areas. And you have sort of that not in my backyard, not in my community type of perception. There's also a lack of social supports, because in rural areas, there are very insular social networks. And this quote over here on the right-hand side of the screen shows that when people get out of, especially residential treatment, this counselor is saying they're going back to the same environment and the same family and friends who may be engaging in substance use, and they don't have those recovery supports. And so a recovery coach could help address some of those barriers. There's also some cultural factors that go into play. And so in rural areas, there is a embracement of independence and pulling oneself up by their bootstraps. And oftentimes substance use is not viewed as a medical issue, but more as a moral issue or individual failing. And so there needs to be recovery community centers to help address the stigma and those cultural issues. And when we have recovery coaches who are from rural areas working with rural clients, that improves outcomes and reduces harms associated with substance use. So I wanted to share one success story. The National Institutes of Health and SAMHSA have created a new initiative called HEAL, which is helping end addiction long-term. And it's focused on reducing the opioid epidemic. The flagship study is called the Healing Community Study, and 4 states received awards for this project: Kentucky, Ohio, Massachusetts, and New York. At Kentucky, we received an $87 million award. It's the largest grant that the University of Kentucky has ever received. And we are tasked with reducing opioid deaths by 40%. So you can imagine it is a lot of money, but that is a lot of opportunity to improve the health and well-being of Kentuckians. So one of the ways we're doing this is we're working with community coalitions. So it is grassroots driven, but we have been working with a recovery community center called Voices of Hope. And Voices of Hope is an RCC or RCO. It's based in an urban area, but they use a hub and spoke model where they have recovery coaches who live and reside and are from rural areas. And we've been able to place rural recovery coaches in a variety of agencies that are listed here. And they're able to provide overdose education, distribute free Narcan to individuals. I think we've distributed over 50,000 Narcan units in the past year. They help build recovery capital and address barriers to treatment, especially medication treatment for opioid use disorder. And they also do direct linkage to medication treatment for opioid use disorder. And there's just a quote here at the bottom from a recovery coach who is in a rural jail, and he used to be incarcerated in that same jail. And he's talking about the freedom of coming into the jail now and helping others with new ways of looking for resources and living. And lastly, I wanted to share, as part of another NIH project called Jcoin, we are trying to create a scale to measure the relationship between recovery coaches and clients. And there's a lot of literature out there on scales that measure that therapeutic alliance between a counselor or clinician and their patient or their client, but we don't have anything like that for recovery coaches or peer support specialists. And so we are in the process of developing this, getting feedback from individuals with experience with recovery coaching. We've pre-tested it with focus groups, and now we've piloted the tool with over 100 individuals who have recovery coaching experience. So we're excited to get that out into the literature and to be able to share with this group as well. Thank you so much for your time today, and I will pass it on to the next person.
Wonderful, thank you. And I will say in the chat here, we had questions about using technology to overcome some of these transportation barriers, and that is exactly some questions that we'll have our two speakers speak to next. So the question is still there, and if other people want to chime in about it, please do share. We'll have Joey go first to answer some of these. All right, Joey, over to you.
Okay, thank you. Good afternoon, everyone. My name is Joey Supina. I'm definitely a person in long-term recovery. I've been doing this for 48 years now, and over half of which has been running as the executive director of a RCO. We call them RCOs, RCCs, where you call them. Next slide, please. One of our unique challenges, there are many, and if you go to the next, my answer. One of the things, everyone that works at our facility, we have no membership. Everyone that works there is a person in long-term recovery. We're open 7 days a week. We have meetings in the evening. We have the Ohio Department of Rehabilitation and Correction. We have parole meets there. We actually have a high school that comes in and does actual high school with the young people that are challenged. They actually get a high school diploma, and we do that. But we need qualified peer supporters to do that. We actually do the Jobs and Family Services. We work with them for people who have lost their children. We have qualified peer supporters who have not only lost their children, but are also successful in recovery. So the demand is very high. We have probably right now, I think we have 25, maybe 26 people that are actually working for us that are in recovery, long-term recovery. And we have, I believe, 5 peer specialist supervisors that we oversee all of these folks. And one of the things that what we really try to highly stress, is we try to remain trauma informed and make sure that we do not do any more trauma. We have people, we go into the jails. We actually have an outreach for people that come out of prison, citizen circle, and we ask them, not what we don't say what's wrong, we say, what do you need? What happened? What can we do to help you? So that's part of our peer support workforce. Next slide, please. What barriers do people in your community experience in accessing your services? Next slide. Well, it's difficult for participants and peer supporters to get the transportation needed. I'm in charge of 23 counties in Northwest Ohio. It's called the Statewide Advocacy Network. And I have to make sure, I'm kind of a pass-through funding source for 11 RCOs that are in that area. But the challenge really is some of these communities are very small, or no communities, almost non-existent. They're just out in the farmlands. And so we have to make sure that somehow we reach those people. And one of the things that is very a challenge, anyone that's suffering, well, not everyone, but generally speaking, people that are suffering from mental health challenge or substance use disorder, they're financially embarrassed. They don't have the funds to really meet the need that they have to find the sources of recovery that they need. So we tried this solution of telehealth, but we didn't have the same effect as I thought it would have. Now, we still do that. I mean, there's no question that we do that. And we do Zoom. And even when, COVID happened, and we took advantage of being somewhat closed down. And I applied for a $500,000 grant to completely renovate our facility. And part of that was to reach people through Zoom and other means so we could connect with them. And at the end of the day, we finally completed our renovation this last September, and it was over $1 million. And we had the state of Ohio come in, and we thanked them for the part of the grant money. So that's part of our solutions. We've been in this community. We're actually in the center of Sandusky, Ohio, in the gentrified area. And we've been fighting stigma for quite some time, but that's part of reaching out and reaching out not only to the people through telehealth, but reaching out to the local stakeholders to let them know that we're part of the solution to this immense problem. And visiting participants where they are rather than waiting for them to come into our RCC. We go out to them. So that's our challenge. And I think we're meeting it fairly well considering the COVID, which happened and all that. Next slide. How might the overall mission, model, and services you offer as a rural RCC differ from urban or suburban? My next slide. Again, it's transportation. That's our, like I said, some of these places that we work with are over 120 miles one way. And we work with the Northern Ohio Psychiatric Hospital, which is in Toledo, which is about 60, 70 miles away from where we're at. And so we have a working relationship with them. And so we often have the RCC participants, we visit them, instead of having them come into our center. Now, they're more welcome to do that, but we do use the telehealth to do that. We actually have classroom participations via, Zoom. We just can't wait for people to come into our center. We need to reach them physically and emotionally. The human touch is really, really essential. I know during the COVID outbreak, we lost quite a few people because of not being able to have that human touch involved. And again, we're open 7 days a week. We open at 9 o'clock in the morning and we close about 10. And it's a long slog, but we found over the years that it's important that we meet people where they're at. The peer workforce, rural RCCs need a larger workforce because we're going way out distance-wise, and traveling takes quite some time of our peer support workforce, and we need to make sure that they're compensated, for their mileage. So it may take a person, like I said, to drive 120 miles on some rural roads. That's a couple hours one way sometimes. Now, not everybody's 120 miles away, but we encounter that. So it's quite difficult to make, but we don't want to lose them because they're just as important as somebody that lives right down the block from our RCC. Can we have the next slide, please? To what degree do you think telehealth can overcome unique challenges encountered by rural RCCs? The next slide. Okay, basically, just what I was saying, if properly supported, telehealth could be a viable recovery tool. And it can solve the problem of distance. And I'm a firm believer in the 5 pillars of recovery. I add hope as one of the my own personal addition to the other 4, because any journey that begins, you need to install hope in a person's recovery, that they can recover. And that journey begins with making sure that they're healthy. And so I'm on a couple of boards. I'm the vice chair of the Ohio Mental Health and Addiction Services Planning Council. I'm also a board member of our county health department and a board member of Ohio Peer Recovery Organizations down in Columbus. So I want to make sure that these people receive the health care that they need. The next thing that a person needs is a home. Now, we just opened up a 48-bed women's, about 2 years ago, just before COVID. And we opened up a 48-bed transitional housing for them. So the thing about a home is that it doesn't necessarily mean a freestanding building that you own yourself. A home is a place, it's not an address. A home is a place where people love you. So if you're in a recovery halfway house, but you're loved there, you're home. So I want to make sure that people hear that. And the other thing that's really important that I highly stress is purpose. When I got up this morning, for the last 48 years, I've had a purpose to do something with my life. We need to install that into the people that we're trying to get into recovery. And when I was one of the I was on the committee to establish the peer support specialist curriculum. And I was one of the very first teachers for the state of Ohio's peer support curriculum. And I think I did the first class. And I would tell people that were coming to our class, I'm going to take your greatest liability and I'm going to turn it into your greatest asset. I'm going to give you a purpose in life. You're going to be able to join the peer support specialist workforce. And so that's how I would tell them, your liability is now your asset. And then finally, the last thing is community. It's in our name. You know, substance use disorder and mental health challenges happen in isolation. Recovery happens in community. It's just quite that simple. We don't have any membership requirement. People just come in. We don't care. We don't ask what's wrong with you. We ask what happened. You're more than welcome to come into our facility. And when you do this in person, it is much, much more effective. Next slide, please. What are your asks of the recovery scientists, clinicians, healthcare decision makers regarding rural RCCs? Next slide. I think I mentioned I'm on the Planning Council. I'm the vice chair of the Ohio Mental Health and Addiction Services Planning Council. When you need transportation, I know I would love everyone to have a van, but vans cost money. So quite frankly, what we need more than anything is funding to make sure that whatever this local RCC 60 miles away from me or 120 miles away from me gets their needs met. The next thing, and I've been hammering this home, I know for 26 years down at the state. When we speak of stigma, we use the term bias and prejudice. But what we need to use is the term discrimination. When you use the term discrimination, that is now a legal term, and people can get sued for not doing the right thing. So I've been stressing that down there. And finally, when I'm down at the state, like I said, I'm on their planning council, I use the term mandate. We should mandate that the counties have access to RCCs and peer support services. In other words, every local ADAMIS board or mental health board or whatever they're calling it in your state, if they do not have access to a recovery community center or peer support services, they don't get funding. That will change the dynamic of everyone across the country. The word mandate and discrimination are very, very important. I think I've spoken for more than 10 minutes, so I don't want to take up anybody else's time. If you have any questions, feel free to ask. Thank you for listening.
Thank you so much, Troy. That was excellent. Jennifer, we'll go straight to you.
Hey, good afternoon, everyone. I am Jennifer Langston. I'm a person in long-term recovery, and I'm the executive director of REBOOT Jackson. We are a recovery community organization about an hour north of Atlanta, Georgia, and we are located in a rural area. You can go to the next slide. So what are the unique challenges you face as a rural RCC? I think our biggest challenge is linking people to resources. I identify with what Joey said about, having access to safe and supportive housing. We have a lot of peers that come to us that are either living in a situation that's not conducive to their recovery, or they just simply don't have a place to live because they've been incarcerated. And we have a big lack of housing in general for everyone, but it's even harder when there's barriers, including background checks or having the proper amount of money to rent somewhere to live. Along with that is access to inpatient treatment or recovery houses. We do have a lot of inpatient treatment in our state. None of them are very close to us, and they're all very hard to get into. Detox centers and crisis stabilizations. I think someone else was talking earlier about having to lie and say that you are in a state of having suicidal ideations just so you could get into treatment. And we definitely have that barrier here too. I just don't think there's enough support for people that are trying to get into a place where they could take a break and get better. So we're trying to figure out transitional housing for our peers, and as a community we're kind of coming together to look for better options, try to get the state to fund more detox centers and places where people can go. You can go to the next slide. What barriers do people in your community experience in accessing your services? I think we can all agree that transportation is a big barrier. We have a community that we're one of the biggest counties in the state of Georgia. So we are also servicing more counties than just our county. And there's no public transportation. No one can walk to our recovery community center unless they're in the jail that just happens to be down the street. We definitely have a big barrier with people being able to get to us and to get to the other services they need. We have been fortunate that we've been given a van to transport people with, and we're able to take them to supportive things that are going to help in their recovery. We can transport people to doctor's appointments, to their psychiatric appointments, to anything that's going to help support recovery for them. And we just keep on seeking funding so that we can have more drivers and more people transporting other people. We don't have Lyft or Uber, anything like that in our community. So we basically are the end all be all of getting someone somewhere if they don't have stable transportation. Next slide. How might the overall mission model and services you offer as a rural RCC differ from an urban or suburban RCC? Well, I think that for us, our mission is to make recovery the expectation, not the exception. And so our focus is on really helping people find recovery and find that community. And I know Joey talked about, how we all have a home, and our home is what brings us together. So for our RCO, we are definitely into fostering that community. We're having activities at our center. We're having meetings here. And I think the great thing about it is that those peers are able to come together and see the same people very often. And I don't know if that's true so much in an urban area. It may be, but I know for us, like, our community is kind of small, and our recovery community, in my opinion, is very large here because we all foster that sense of belonging and family, so that we can get people together and have them have that supportive community. So I think that we probably may to offer different services than an urban RCO. We are able to, we just had actually the other day our very first GED graduate. So we've partnered with a local community college that may be a little far away for some of our peers to get to. So they have made us a satellite branch of their college so that we can help people get their GED if that's a support that they think they need to progress. We've got, like I said, the transportation services, and then we just try to offer people anything that can meet them where they're at. And that may look different for us in a rural area than it would for someone in a more populated area with better access to transportation. Next slide. To what degree do you think telehealth can overcome the unique challenges you've encountered by rural RCCs? So I am torn about telehealth, I will be honest. I think telehealth is great when you have a follow-up visit with your doctor, or when you are trying to do something that, may be able to be accomplished by just simply talking and seeing someone on a screen. But for us, I think it is always better when we're in person. And I hate to say the A word, but we say the opposite of addiction is connection. And it's really hard for me to feel that connection when I am on a screen talking to someone, because it's just different. So I think there's also the barrier of people not having access to the internet, people not having access to a smartphone, or not having service on their smartphone in their homes. So I think it's a big deal for us to get people in here and to talk to them. And I love the idea of going and meeting people at their house. That's great. I think I learned something today, and I want to try to see what we need to do to get that going. But, it's fostering a sense of community, and and it's letting people know that they're supported. And I just don't think it's as personal when we are on a screen as we are in person. Next slide. What are your asks of recovery scientists, clinicians, and healthcare decision makers regarding rural RCCs? Well, the first thing I think is that we need more ways of getting funding, more sustainable ways of getting funding. You know, grants are great and they don't last forever. So if we could partner up with other agencies, if we could partner up with our state, and just find different ways to make it so that we know we're not going anywhere and we're going to be able to service people throughout their recovery. We did also talk about partnering with different financial institutions. Academic institutions, more clinics, you know, just to maybe do some research or to figure out like how we can collect data more effectively. And then my other thing that I talked about when we were bringing up these topics was we have a lot of medication assisted treatment providers in our community. And I think there's definitely a disconnect between our services and their services that we could be partnering together more. We could be helping each other. So I would like to see more warm handoffs between the two of us. We are very mindful of stigma, especially surrounding medication assisted treatment. We want to support everyone in whatever pathway they're choosing. And I think that maybe those clinics aren't on board with the mindset that we have, because we are, there's just usually a stigma surrounding medication assisted treatment that I would like us to be able to break that barrier and come together and do more supportive services around that. And then data collection, I'm always 100% on board with collecting more data. We do use a platform provided by Faces and Voices of Recovery to collect data, but I would really like to see a more universal standard among RCOs and RCCs where we could use that data meaningfully to maybe get more funding. And I think if we were all on the same page with what data we're collecting, then we could definitely go in that direction. So I think that was the last question. Yeah. So thanks, guys. If you have any questions, let me know.
I was muted. I said, thank you, Jennifer. That was wonderful. And also for all of you, you now know why we had Jennifer go last, because she's doing our plug for data and collecting data. And certainly what you just said about, you know, a common metric that we can all use. We're working towards that with our repository of scales. And maybe Hazel or Katie, you guys could throw the link in here. This is an ongoing effort that we have. Right now, we're just kind of pulling together different scales that other people have used that may be useful in our ongoing survey. Some of them are presented in that survey where we say, this is what exists and what do you all think about how useful that would be? That's your way, your quick way for you all to let us know what would be a good scale. And then keep the ideas coming. If there's something that you think is currently really hard to put into your reports that you wish could be measured more effectively, let us know. We'll look around. If you have a great suggestion, something that worked well for you, let us know so we can share it with other people. I totally agree with you, Jennifer. We need to work better on figuring out what the best metrics are and sharing tools to that end. And that's what we want to help. And that's what we want to do in this setting. So please support that. All right. And then I just want to say thank you to all of you. Thank you, Jennifer, Joey, Carrie, Heather, and Brandon. It's great what you presented. We have a few minutes left, and I just want to ask everybody in the room if there's a thought you wanted to share, a comment you had, an experience that was similar, other ideas or solutions you had. I wanted to open it up to all of you.
Hello, everyone. My name is Sabrina Roberson. I am a public health research associate with TCU, Texas Christian University in Texas. And I just got added to the Jcoin project this week. So getting that data for you is our primary goal to close the gap and get more funding for the RCC. So enjoyed all of you, great information. I'm going to share this with my group on Monday. So thanks a lot.
Awesome. Thank you. Other questions from the group? I know that we had the question earlier from, I'm scrolling up, from Carolyn about the telehealth, and you heard some answers. Did you also have thoughts about it you wanted to share?
Yes. Hi, can you hear me?
Yes, we can.
Hey. Yeah, so I've I have got a very personal interest in recovery. My daughter overdosed and died 4 years ago, and I run a technology company today that has a very significant distribution partner that you guys would all know. Think 5G and Jim Carrie, maybe you'll figure it out. But we're all kind of circling around, how do we assist organizations like you with technology when people don't have transportation, they don't, they want, being anonymous is more important to them. Clinicians are not readily available in rural areas. And, you know, what you guys responded was, well, there are barriers because people don't have cell coverage or internet access. And I think that's definitely something on the top of the government's mind about how to fix that. Before the pandemic, we were very well wired into the rural opioid task force under Trump. Now Biden has announced new initiatives. So it sounds like your key challenges are to get funding moving downstream so that you have the money to either bolster what you do in the live world, but also consider perhaps bolstering what you might use technology for. So for me, this was quite interesting. It reinforces most of the things that I already have learned over time. And stand by, I think help is coming your way in a more significant way than you think. So it was incredibly interesting to me to hear what you guys were struggling with.
Thank you so much, Carolyn, for sharing that. And I'd also like to mention to you that last month we actually talked a lot about telerecovery, and some advances have been made there in different models. So I encourage you to check that out, that recording, if you haven't already seen it or are already aware of those resources and ways of doing things. Great. Other questions, comments, thoughts? Or are we actually ending a seminar on time? I think that'll be the first time ever in the history of the series.
I just wanted to say that I love Joey's framing of discrimination versus stigma, because language does matter. And I really like how he described that. That makes sense to me in terms of calling it what it is, discrimination.
Totally agreed. And we also got lots of positive feedback here on the hope. I think lots of people were resonating with that as well as an important first ingredient to embark on the journey.
I would just like to say, so my name is Roxanne. I'm a person in long-term recovery. I'm also a budding recovery science researcher. But I really like, first I like Mr. Supina's about going to people, because I agree, addiction's very much isolation. And I see a lot of like trying to get people out, but sometimes like we definitely have to go where people are at and meet them there. So I thought that was a great comment. But I also wanted to bring up, so Miss Heather Rodriguez at the RCC that she has in Indianapolis, I really loved the RCC with childcare. So my dissertation and my primary focus is on parenting in recovery, and specifically long-term recovery, because we tend to focus more on those initial, all the studies tend to focus more on the initial stages of recovery, the early stage of recovery, and how, you know, parents get their children back and stuff, but we're missing this whole other subset. And unfortunately in my life, I've seen a lot of my friends, we get beautiful children, beautiful lives, and then are not able to balance, and, you know, it doesn't always work out well. So, but there are people who do make it out well and balance it. So I'm interested in that. So I think it's really important about the childcare, because I think we're missing an entire group of people, specifically because of our society, women that are not able to either sustain their recovery or initiate recovery because they have these child care. They're the primary parent, and it's huge. It's huge. It's I can't even tell you the amount of women I talk to that are unable to take care of themselves because of the taking care of their children. So I thought that was fabulous. Absolutely excited to hear about that.
So true. And I think that's an excellent note to be ending this meeting on. Thank you all. It's been great. And we will send out the email with a link in the video recordings and the slides. If there's any other questions you guys have down the road for outreach, I know somebody asked for an email address, but now we're already offline. Email us. We will always get back to you guys.